Hi guys, good evening. How are you? How are you all? How are the things? Good evening. Happy New Year. Wishing you all a very happy New Year, guys. Wishing you all a very happy New Year, guys. Okay, and I think we should start. We should not take much time, guys. We have, we couldn't, take class because of my exams, yesterday and day before yesterday. So today we will take the class on the things whatever we were discussing before. So can someone just guide me a bit what we have discussed in the last class, guys? Can someone tell me what we have discussed in the last class, please? Yes, people. Yes, guys. What we have discussed in the last class, tell me. Fast. Yes, guys. Applications of DUE in research. Yes, absolutely. DUE in research steps we have completed. Did we do the steps? Oh, yes. We completed the steps. We completed a few types of research studies, and we completed with few examples. So there are many more things remaining in the DUE. So let me start. Okay, let me share the screen. Let me start because it's going to be a long class today. Okay, it is going to be a little long class today. So I'm just sharing the screen, guys. Yeah. Okay, so let me share the screen. Yeah. So till last class, I believe we have completed evidence-based practices, right? Isn't it? We have completed evidence-based practices related classes, right? Evidence-based practices related class related research to the DUR, how we can use the DUR and evidence-based research. Like we talked about systematic review, we talked about meta-analysis, we talked about like some studies, retrospective, prospective data, and we talked about practice-based research network, also PBRN studies, right? So today I would like to, as I told you that there are many types, and that day also we have, discussed those parts. So today I'm going to talk about some more studies. So just wait. Okay. Yeah. So today we are going to talk about, wait, let me write here. Today we are going to talk about, I think this is the fourth type of study. And let me increase the pen size a bit. Yeah. So today we are going to talk about nothing else but what? Cost effective analysis. Cost effective analysis. Analysis like CEA studies using DUR or DUE, right? In last class, we talked about evidence-based medicine. We talked about the safety databases. We used about drug safety. We talked about treatment options. We talked about medication adherence. We talked about therapeutic outcomes, optimizing therapeutic outcomes, and all. So today we'll be talking about other related studies. And first, let's start with cost-effective analysis. Okay, cost-effective analysis. So why exactly do we do these studies? Cost-effective analysis. First, we have to understand why do we do the cost-effective analysis. So, as in our my last course also in epidemiology course we discussed about the cost effectiveness of the government policies or the medicines or the drugs or treatment or any therapy, we work on, like optimizing the long-term cost, right? Optimizing the long-term cost, right? And along with that, we also talk about the different treatment strategies which we can use, right? So we compare the different treatment or therapy strategies, different treatment strategies, right? Treatment strategies. So this is there, but how do we exactly use? Let's take up with an example. Let's take up with an example. Like, see, uh, suppose there is a patient, guys, focus here, how we can, construct a study over CEA, cost effective analysis, how we can construct a study over CEA, right? So suppose there is, we have to evaluate the cost of suppose novel anticoagulants, okay? Novel anticoagulants, right? Suppose anticoagulants, OACs, oral anticoagulants, we call them anticoagulants, right? So what are oral anticoagulants? Can you give me example? We call them NOAC, novel oral anticoagulants, okay? Or new oral anticoagulants, we call them NOAC, 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 right? So can someone give me example versus warfarin, because these are the two examples, these are the two, drugs what we usually use in the patients with AF, atrial fibrillation, right? Atrial fibrillation. Okay, atrial fibrillation. I'll come to the simplest example also. I'll come to the simple example also, but let's understand first this. Okay, let's understand this. See, so I want to check the cost effectiveness of novel, anticoagulants, oral anticoagulants, OAC or NOAC we call them, versus warfarin. In what? I think we have discussed this example in, last class also. The same example I have discussed in the evidence based part also. Like, how do we, check which therapy is best in, optimizing the outcomes for stroke. So here we are not checking the outcomes, but here we are looking for, like decision modeling, we can say. Here we are looking for the decision modelings to check which, drug or which therapy is cost effective, either, NOAC or warfarin. So guys, did you guys answer what is the example of NOAC? No, nobody has answered what is the example of NOAC. Are you people answering this? Give me the example, one or two drugs from NOAC, NOAC, no, new oral anticoagulants. Hey, come on, guys. I know you guys are from PharmD and BPharm and, MD people are also here. So give me some examples. Yes, guys. Okay, so let me give the example here. Yes, Meghna is written like apixaban. So see, there are the examples. If I tell you apixaban, okay, apixaban, uh, apixaban, rivaroxaban, okay, rivaroxaban, and there is tirofiban also. Okay, tirofiban comes in injectable forms. That is not oral, but rivaroxaban, rivaroxaban, and dabigatran is there. Yes, dabigatran is there, right? So these are oral anticoagulants, and we give warfarin. Warfarin is the first generation traditional drug. Warfarin is the first generation traditional drug for stroke, or the in the cases of blood lithiasis, we use warfarin. So when we have to compare this, the drug cost effectiveness, exactly, when we check about the cost effectiveness, then what we have to do is we have to make the we have to make some parameters to check. We have to make some parameters to check, right? We have to make, or we have to take some parameters to evaluate the cost effectiveness. Can you tell me what would be what would be those parameters we usually check in cost effectiveness studies? Can someone tell me? Yes, guys, I'll explain this to everyone, don't worry. I'm just asking you, I'm just checking your knowledge. How much do you know about this? Can someone tell me, how do we know how do we compare two therapies for cost effectiveness, or for any cost effectiveness? What kind of parameters we check? Yes, guys, what parameters we check? Array, in my last course, I told you, many of you are from there. No efficacy and dosing. No, 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 no. We check what we check? Unit price. No. What we check? Unit price with? Array, look at this. QALY. Quality adjusted life years. Right? Quality adjusted life years. You know what is quality adjusted life years? Quality adjusted life years is, see, suppose there is a patient with heart attack, right? And suppose the patient has the life after angioplasty, he has the life of 5 years. Okay, or maybe without angioplasty, just with the traditional balloon angiogram, or balloon angioplasty, the patient has life for 5 years. But what we do is we give medications, and we also do the angioplasty, or we only do the angioplasty and give some medicines, and the patient's life increases by 3 more years. Patient lives for 8 years, right? So the 3 years are quality adjusted life years. Okay, this 3 years are quality adjusted life years, like increased with the medicine, increased because of the medicine. These life years have been increased because of the medicine, or the therapy, or the management, whatever we did for the disease. Understand? So these 3 extra years are counted as QALY, quality adjusted life years. Understand? So whenever we want to check the efficacy and cost effectiveness is not short term. Okay, that is cost comparison, guys. Focus on this. Cost comparison is short term. Like if you want to check just the, like, what is the cost of Parle-G and what is the cost of bourbon, then you will find out that, oh, one is 20 rupees, one is just 10 rupees. So there is a 10 rupees cost. That is price difference. But when we talk about healthcare cost effectiveness, it includes the benefit to the patient. Okay, it includes the benefit to the patient, and benefit can be only counted by QALY, quality adjusted life year. So how the quality is being improved. So QALY is not just the 3 years, 8 - 5, no, it's not 3 years only. It is like, it is also been counted with some quality related questionnaires are there. We measure, we administer some questionnaires, we administer some other instruments, and then based on that we find out how much life was exactly adjusted with that, adjusted with the medicine, and adjusted without the medicine, right? So we compare the quality of life, and then we multiply with the increased years. Okay, and that quality of when we check the quality of life by using the questionnaires, there are multiple questionnaires, like KCCQ is there, as and there is European quality of EQ5, European quality of life questionnaire, with 5 dimensions, and then there is uh, what we say it SF36 is there. So these are the major questionnaires. Based on that we can find out the health related quality of life, and that health related quality of life will help us in getting the quality adjusted life years. Okay, there is a different formula. I have taken this in my last course. I mean, that's not necessary here, but I'm just telling you, like, to understand how do the things work here, so whenever we go for the cost effective analysis, we usually do not check just the price, but along with price we check the quality adjusted life years, and based on that we find out the effectiveness of drug, we find out the cost effectiveness of the drug, and we try to make the new strategies according to the cost. Okay, and what we use at the end, what model we use here at the end, model we use here, just remember this. I'm not going to the difficult part of this. The model is called as Markov model. Okay, Markov model. I'm not going to the Markov model, otherwise the entire class will shift to the other things. So I'm just telling you the example, how do we do that. Okay, and if you want to construct the studies, that is an example, like you can construct the studies based on this. Now I'll come to the a little little less cost effective wala part, little less tough part. Okay, little less tough part. So what we do is like what we can do is like we can compare suppose there is one thing. Suppose someone got accident. Okay, someone got the fracture in hand. Someone got fracture in hand, right? Someone got fracture in hand, and there are two things. Either he goes directly for the surgery, right? Either he goes directly to the surgery, option A, option one, right? And option two is he goes for the plaster, like no surgery, no invasive surgery, just plaster with some medications. I mean, definitely surgery also with medications, but plaster with medications. One is invasive, one is non-invasive. So this is invasive, this is non-invasive. Now what the thing is, see, after surgery patient may recover in 1 month and goes back to the work, right? And his quality of life is best. And then in the plaster one, the patient recovers after 4 months and still he has pain and discomfort. Okay. Okay, pain and discomfort, and his quality of life is poor. But the thing is, what comes here is, one sec. Oh, it got logged off. But the thing here, comes is only, one scene is there. What comes in mind is cost. Okay. Why I'm telling is previously we were talking about quality of life. We were talking about quality adjusted life years. But here we talk about what? Here we talk about cost, because in surgery the cost will be much higher, and in plaster the cost will be much lesser. Okay, understand? The surgery cost might be suppose 80,000 and plus medications, and in plaster it might be just 5,000 plus medications, right? So you can check out 80 and 5, there is a huge difference, right? So based on that and quality adjusted life years or months or whatever weeks, months or weeks, whatever we count, quality adjusted life we have to check, and based on that at the end we find out what is more effective. Either the surgery is effective or plaster is affected. Okay, plaster is effective in for the patient, right? So based on multiple things, not only this, based on cost, based on the the drug costs, hospitalization costs, and the procedural costs, and along with that quality adjusted life years, right? So that takes a huge amount of things here, that takes a huge amount of the things here in making a conclusion for a treatment or therapy. But these type of studies are not that tough. Okay, these type of studies are not that tough. You can definitely plan such studies. You can take my help if you really want to do something out of the box. Why I'm telling about these studies, guys, in DUE or DUR, why I'm telling you these studies are because when I'm talking about these studies, at least one of you or two of you will be having that courage or having those resources where you exactly can do such studies. See, I know the people who are in smaller hospitals or who are working in some primary or secondary care hospitals, they cannot have such data to do such studies. But the people who are working literally in the hospitals more than 500 beds or in the tertiary care centers, they definitely can do such studies. And these studies are top in publication, top level evidence, and these studies are the much needed studies to make the financial policies, to make the health budgets, and these kind of studies are required now. These type of studies are required. So that's why I told you that the cost effectiveness is very, very important. So these type of studies you can prepare in the these type of studies you can prepare for the hospitals, like if you are working in the hospital, to compare the cost and all for the different treatments or different health related policies and all, right? But along with that, there is another thing. I'll give you the third example here. I'll just give you the third example here. Like example 3 is population based cost effectiveness. There is one more thing called population based cost effectiveness. Okay, population based cost effectiveness. Population based cost effectiveness. What is population based cost effectiveness? Population based cost effectiveness is like there is no comparison. Okay. In the previous one, we usually find the comparison between two or three costs, or between three or two therapies or the treatments. But in the population based cost effectiveness, we don't find out those things. These studies are usually being done by the government, policymakers or the government healthcare professionals, like from the, as I usually discuss I usually discuss about these PHFI, Public Health Foundation of India, and we talk about ICMR. Those people conduct these type of studies. But guys, let me tell you, you also can conduct such short term and in the less population, right? And those studies will help the government, will help your publications, will help you in life. If you are doing such studies, that can help you in your CV making. That can help you in your getting you trained in such studies, and that's best to join the ICMR, or if you want to join the PHFI, or if you want to join some public health college, or those type of studies. These type of studies are being published in the high impact journals. So you just have to what we say, gather a little courage, and plan such studies, get the approval, and go ahead, because in this you don't need much data. You don't need much data directly from the patient or things. You can do these studies retrospectively also. Okay. If not prospectively, you can do these studies prospectively, I mean retrospectively also. And example, if I want to give you the example, it is like just assess the cost effectiveness. Like suppose cost effectiveness of right now HPV vaccination is going on, right? HPV vaccination is going on. So you can just check cost effectiveness of HPV vaccination in reducing the cervical cancer, right? Reducing the cervical cancer incidences in your area, right? So based on this you will easily get based on this you will easily get the ethics approval also, if you're doing in your area or your city, and you can work on that. So large scale registry also can be done, or you can do at the lower level, just to analyze the core cost and health outcome associated to this HPV vaccine in cervical cancer patient. I mean, young ladies, young married and unmarried ladies, usually unmarried ladies from 13 to 19, 13 to 20, you can do this study at your level also, right? This is the trending thing, and I'm giving you the example, right? So you can plan such studies. Definitely talk to your guides, talk to your mentors, talk to your statistician, plan such studies and do those. Okay. So that was about the cost effectiveness. But if I talk about something now, and now you will tell me how it is related to DUE or DUR. See, definitely it is related to DUR. When I'm talking about drug utilization, that means if the patient is using, like the first example, if the patient is using NOAC, or they are using warfarin, if they are using new oral anticoagulants, or if they are using warfarin for stroke prevention in atrial fibrillation patients, right? If the atrial fibrillation patients are using, I mean the doctors are using warfarin or NOAC, right? So definitely drug utilization is happening. You just have to add the cost of the drug and quality adjusted life here as an outcome and the factor affected, right? So those things you can just add to your research and research protocol, and you can make the study based on DUR data, right? And when I'm talking about the public health wala thing, I mean the public health thing, like HPV vaccination, that's definitely, this is drug utilization, like how many people are getting the what we say, cervical cancer, even after taking the vaccine, or they're not taking the vaccine. So the incidences and prevalences definitely is a part of drug utilization, because that is the adverse event, we can say adverse event, or non effectiveness of the drug. So that's why we check cost effectiveness and effectiveness of the drug by using the drug utilization review data or drug utilization evaluation data. Okay. Okay, guys, any questions here? Any questions here? Anything you want to talk about? Anything you want to add into this? Yes, guys. Please tell me. Yes, people. Anything I need to add or something? Yes. Anything I need to add to this, guys? Do you have any suggestions? Do you have any questions here? You want to know anything else? You understood? You understood or not? Guys, come on, comment. 60 people are there here. Only Dars and Pranav has replied. Okay. Okay, cool. If many people are answering, then I suppose to accept this that you guys understood. Okay, now I will talk. I'll come to the core DUE again. I'll come to the core DUE. Okay, so let's talk about what kind of other studies we can do. Like suppose I want to check the rational use of drugs or rational use of therapies, right? So let's make some studies on rational use of drug. Rational use of drug. Guys, focus. These are the the studies what you can plan for your upcoming semesters or upcoming years. Okay. See, this is simple. When I'm coming to this is called core DUR. Okay. This is called core DUR or DUE. Core DUE, bilkul. So you can plan some core DUE studies and what type of studies, what type of core studies you can plan. So, it is very simple. It is very, very simple. Just find out, and whatever you are doing right now, I have seen many colleges, they just do one thing, but I will tell you how to do it systematically. How to do it systematically. What the people do is, you must have seen many of you being a PharmD fifth year or sixth year, or people, your faculty members have done that, and they must have asked you to do that. Okay, ask you to do this. And what is this? What is this simple term? If I tell you, that is, guys, you are aware of this, right? Prescription pattern. Prescription pattern, right? So you are doing a lot of such studies, but today I want to tell you a little more about this, and I want to add some more things to this where you can literally do some good studies. Suppose, see, let me take one simple example for, like, let me take some simple example here for you, right? So it is like, I want to assess the antibiotic prescribing pattern. Antibiotic prescribing pattern. Prescribing pattern in suppose OPD clinic. OPD clinic. Why we are doing this? I'll do this to identify overuse or misuse of the overuse or misuse of antibiotics, right? Misuse. So misuse of antibiotics. So guys, now this is one of the core study I brought to you, and you must have done, you must have thought of, you must have either thinking of, like, this is one of the simplest study. Guys, you have to participate with me, and you have to construct this study with me. Okay, you all have to construct this study with me. Okay, assess the antibiotic prescribing pattern in OPD clinic. In OPD clinic. So I'll just clarify some more things here. Like I'll start constructing the things. So this will be this is, suppose, the general physician. Okay, general physician. General physicians. Here there are three general physicians, and the department is general medicine. General medicine. Okay, and they prescribe the medicine. So department and the prescriber is general physician and general medicine, right? In the general medicine department, general physicians are prescribing antibiotics for any disease. For any disease, any type of infection, they are prescribing multiple antibiotics. I'm saying that. Okay, so guys, now suppose I have the objective also here. I have the objective also here, assessing the antibiotic prescribing pattern only. Okay, in OPD clinic, to identify the misuse or overuse. Misuse or overuse, right? So first of all, Tell me one thing. Tell me one thing here. What type of parameters I should use? What parameters I should use? Parameters means suppose I'm writing a protocol and along with protocol, I have to prepare one case report form, right? Case report form. So what type of things must be there in data collection form or case report form? CRF is data collection form, right? This is also called as data collection form. Data collection form. So you guys tell me how to plan it, what kind of things I should work on, what kind of indicators I should take for this. Yes, guys, tell me. Tell me, guys, tell me fast now. What you will see when you want to take, when you want to do the prescription pattern, what do you need to get the conclusion of prescription pattern? Yes, people. See, you just have to think like you want to check what kind of prescriptions are written, what is the use of prescriptions, where is the use of prescriptions. So to check this matter, to get a conclusion on prescription pattern, what I have to check, what exactly I should take into the consideration so I can look into the things. Okay. Outcome. Trisha is telling outcome. What is outcome here? Tell me. Yes, outcome. Please tell me here a little bit about outcome. Rationality of antibiotics prescribed. What is that? Thus, it is a very broad term. Rationality. How do we check the rationality? This is the objective. This could be the objective. Yes, guys, you're right. Which one is the most used? Empiric, definite therapy. Okay, definite therapy, prophylactic. Quite amazing. Yes. Therapeutic outcomes toward disease or infection. Okay. 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 See, first of all, guys, focus. I think you guys are not getting the question, or maybe you guys are not understanding this clearly. Let me tell you one thing. See, when I'm talking about prescribing pattern, okay, focus here. When I'm talking about prescribing pattern, what is this here? When I'm talking about prescribing pattern, prescribing pattern, again, check this word. It doesn't have, anything doesn't relate with outcome. Okay, it doesn't relate with outcome. So outcome is out here. We are nothing to take with outcome. When it comes to prescription outcome or prescribing pattern or prescription pattern, this always go for the prescription only. And what we look into the prescription is, first thing, remember, if you are constructing such studies, if you're constructing the prescription related studies, guys, focus. You can make it, because many people, they don't know how to do that. They don't know how to do that. Let me tell you one thing. First question should be, why. Number two should be what. Number three should be whom. Number four should be what is that? Okay, what could be in multiple things? So major three things are why, what, and whom. You have to check for that. Okay, you have to check for why, what, and whom majorly. These three things you have to check. Now, what exactly these three things? Guys, focus here. When we are checking the prescription, we have to look into this. Okay, first thing you have to check the reason. Okay, the reason. Why? The reason could be your objective, your objective, your subjective, whatever. Okay. Okay, like your sign or symptoms, anything. Sign or symptoms, anything it could be, right? Or any suspected or diagnosed disease, whatever. I mean, based on sign and symptoms, any suspected or diagnosed disease, right? In case of antibiotic, usually we suspect the virus, or I mean, sorry, we suspect the bacteria, right? In case of antibiotics, we suspect the bacterial infection, right? We suspect the bacterial infection. That is completely absence anyways nowadays. Whenever the person goes with even the viral infections or fungal infection or any other infection, they prescribe the antibiotic. Okay, irrationally they prescribe the antibiotics. They don't wait for the reports, they don't wait for the time. If you go with the fever, they will tell start antibiotics, start augmentin, or anything, azithromycin or whatever. They give the medicines, they don't check what exactly the reason is, right? So first thing, focus here. When I'm talking about why it is given, why means the objective or subjective reason should be there. That is either sign or symptoms or suspected or diagnosed disease. Okay, one thing, I'll come to the major part here, don't worry. I'll construct the entire thing. Then what? Okay, then the second part comes is what they are giving. Okay, then the second part is here, what they are giving. What means which antibiotic, which category of antibiotic. Okay, antibiotic, because we are talking about antibiotic patterns, right? And along with antibiotic, what additional they are giving, what additional they are giving, right? Additional therapy, right? Additional therapy. Now, whom? Very, very important. Your population. Either those are adults, those are women, pregnant, maybe not pregnant, pregnant, whatever. Those are maybe pediatric population. Okay. Why we are taking whom? Why we are taking whom? Because in antibiotic prescription, population is very, very important, because in all three type of patients, that works differently, that works differently. Okay, so you have to keep these things in mind, guys. You have to keep these things in mind. And then when we are talking about antibiotics, what is not only the drug, but what is also like dose, frequency, right? Duration. These all things you have to check. These all things you have to check. Understand? Keep this in mind. Nobody will tell you these things. You have to keep these in mind when you are doing any kind of prescription analysis, or any kind of studies I'm talking about. Okay, prescription patronization, or prescription patrons, or prescription analysis, or whatever type of studies you are doing, you must keep these things in your mind. Why, what, and whom. So why could be any reason. Now let me tell you. See, let me take this example only further. Patients are coming to OPD. Patients coming to OPD. First, define the population only. Let me define whom only first. Okay, let me define whom only. Like, what is this study? See, if I'm talking about whom, there could be the young like pediatrics, pediatric patients, right? Pediatric patients with, suppose, cough, fever, cold, normal I'm talking about. If we are checking the, if we are checking if pediatric population, right, they'll come up with a fever, cold, cough, or maybe some stomach pain for longer term, right? Stomach pain, or maybe some swelling in the arm or wherever, right? Swelling in the arm, or that kind of symptoms the patient can come up with. Okay, that kind of symptoms the patient can come up with pediatric population. Okay, and if we talk about adult population, maybe when they're coming to the physician, they can come up with anything. Okay, like they can come up with fever, they can come up with cold, and cough. They can come up with, what, they can come up with surgery, accidents. They can also come up with the some, like, suppose myocarditis, carditis, and all, like heart problems, right? They can come up with teeth problems, right? Oral infections, teeth infections, right? So there could be multiple reasons. I mean, when they come to the physician, they don't need any specific reason. Physician is like, they come to physicians for everything, right? If they're coming there, if they're coming for, like they're coming diabetes, with the diabetes mellitus, and with the diabetes mellitus they have diabetic foot, right? They come there, right? So in all the cases, antibiotics might be needed. Or not only this, but if they have other problems also, and they are coming to the doctor, maybe there are multiple symptoms. I'll not go to that. So in the adults, then again, the pregnancy, pregnant women, or other vulnerable populations, they come to the doctor, they have these symptoms, right? So they can come up with these symptoms, older people, young people, and all, right? So when they come to the doctor, what they usually see, they either do the test or they don't do the test. They prescribe what, right? They prescribe what? I mean, before prescribing, or maybe, I mean, these two things can go parallelly, what and why, right? So they have to suspect, they have to look at they look into the sign and symptoms, why it is happening here, and then they may do some suppose HSCRP, or maybe they are doing some TLC, or they are doing some HB, they are doing some other blood tests they may do, or they may go for microbiology test also, they may go for blood culture also. If they don't go, they have to, I mean, they will go, if they are going for blood culture, then by the time it will be 3 days, 48 hours to 72 hours it takes, like sometimes 24 hours also. But some bacteria are not growing in 24 hours, so it waits for 20, 48 or 72 hours, right? So by the time the doctor will start, either they will start the fluoroquinolones, they will start other drugs, they will start augmentin, maybe this ampicillin, or they may start the levofloxacin, they may start anything. There are hundreds of the drugs, cefuroxime, or there may be some other drugs also, right? So they can prescribe anything, any dose, any what we say, any duration. Okay. Usually, if I tell you now, I'll tell you why these things are important. First of all, along with these things, when you are checking, you are checking for first the frequency of antibiotics. Frequency of antibiotics, right? Frequency of antibiotic means, like 30% of total prescription are antibiotics. 30% of total prescriptions are antibiotic. Then in antibiotics, 10% are phenoliquinolones, and 10% are levofloxacin, or when not levofloxacin, this augmentin, penicillins, or whatever. There are the multiple categories of the antibiotics. So 15% this, 20% this, you can do that. And then you can use another things, like what was the frequency levofloxacin was given for 5 days, 7 days, and you can correlate all those things with the diagnosis. Okay, diagnosis. And you can check, okay, in fever, this much was this antibiotic. In cold, 50% sent on ampicillin, and 30% sent on cefuroxime, and 20% sent on erythromycin. Like that, you can you can prescribe. I mean, you can do the pattern. You can make the pattern of the antibiotics in that form. You can make that up things. But when it comes to the rational use, right? I have come to the rational use, right? I have to talk about the rational use. Then the major part comes here, guys. The major part comes here. Whatever I was doing till now, it is traditional. It is conventional. Okay, whatever I was doing right now, it was conventional or traditional. But if I want to do it in the better way, if I want to do it something special or out of the box, what I have to do is, I will say, see, when the patient A came to the hospital, he had cough, fever, and rashes over the body, and doctor prescribed, suppose, levofloxacin, 400 mg, 1004, 5 days. Okay. But what happened is, after 3 days, or after 3 days, the culture went there. Like culture was sent to the, I mean, when the patient came to the hospital, culture was sent, right? After 3 days, culture came negative. Culture came negative. Negative means there is no growth of bacteria. No growth of bacteria. See, if there is no growth of bacteria after 3 days, why we have given the levofloxacin? There is no importance of antibiotics, or there is no need of antibiotics at all. Right. First of all, this is irrational use, because when there is no growth of bacteria, there could be some other suspecting things. There could be some fungal infection, there could be some viral infection, there could be some parasitic infection, right? That could happen here. That could happen. It's not necessary it was bacterial. But you will say that then why we cannot wait for 3 days, right? We cannot wait for 3 days. No, see, the diagnosis, first of all, was not correct here. I mean, if I tell you, see, being a researcher, you should think of the rational use of drug, not irrational use. See, they could have done easily the fungus test. The fungal test takes only 3 minutes, 3 to 12 minutes. Okay, 3 to 12 minutes. They just check in the microscope. They just take a little bit of your skin part or the blood, and they check in the microscope, and it takes just 3 to 12 minutes. Okay, and for antiviral, it takes like 5 to 6 hours or 8 hours sometimes, if you are checking for dengue, if you are checking for dengue or other things. If you are checking for parasitic malaria, it takes 3 days. I mean, it takes 3 to 4 hours only, right? So it is not necessary that you directly start levofloxacin and then just send the culture. It is important you check all the other aspects also. Okay, that is one scenario that you have to do it. Okay, I'm just telling you the scenario, then I'll construct everything. Okay, then the next scenario could be, the patient, see, contradicted to this, the patient came with fever and all, and running nose, but the doctor knows, I mean, doctor knows that, oh, this is some viral, and this is not bacteria, and he doesn't prescribe antibiotics. He doesn't prescribe antibiotic, but he doesn't even do the viral test. But he doesn't do the viral test also, or bacterial test. He just say, oh, you go home, you Mr. Whatever doctor, whatever patient name is, you go home, take rest, take some warm water, take some Vicks vapor, take some ginger tea, and you will be fine in 3 days. Okay, after 2 days only, or after 24 hours, the patient's condition worsens, and he came back to hospital. And what happens in the hospital is, the patient, they check the patient's culture, and 24-hour culture says that there is a positive, gram positive bacteria. Gram positive bacterial growth is there in the culture. Understand? So here also there was some mistakes. So again, irregular use was there, right? And the third scenario, I'll tell you, the patient took the medicine, patient took the 5 days antibiotics, and after 3 days, it is very simple. You also do that. I know many of you also do that. Many of your parents do that. My mom do that. She does that same thing. Okay, if she feels like after 3 days I'm fine, then she will stop all the medicines. Sometimes she does this with the BP medicines also. Okay, after 3-4 days of continuous blood pressure medicines, if she feels like, oh, I'm perfectly fine now, she stops the blood pressure medications also. Like, I'm fine now. It doesn't matter. Whatever promises you do, whatever things you do, whatever you try to make them understand, they don't understand. That's the another thing. But being a researcher, why I'm telling you all the scenarios, when you are doing a research on prescription pattern, prescription pattern prescription pattern is not just limited to whatever we did or whatever I told you, like the percentage of the drugs or percentage or distribution of the antibiotics among the different populations. No, this is about rational use also. Rational use also. How will you do that rational use? See, it is a little tricky, little tough, but the best part here is, but the what we say, the khushkhabri here is, the good news here is that it can be done retrospective also. That can help prospectively later. It can be done retrospectively also, and you can check the entire record. You can check the entire record. I mean, see, I'm telling it can be done retrospectively, not 100% retrospectively. I mean, it can be done prospective, retrospective, anything. Okay, so how do we do that? See, in that, what exactly you need? In that, first of all, you need sign and symptoms. You need age, whatever we're talking about, gender, comorbidities, definitely comorbidities, right? Comorbidities we need, and along with comorbidities we need some risk factors or exposure we need, right? Exposure we need. And now it comes to why. I mean, if we do that, objective and subjective, right? Objective and subjective. And then objective and subjective should be confirmed. I mean, confirmation or suspicion, whatever is there, there is a suspicion also. So in the suspicion, what was the diagnosis, right? After diagnosis, the first prescription, what was given? First prescription must be there. Details of the first prescription must be there, like drug name, dose, frequency, duration, right? Duration. So these four things are important to take. And not only this, you should monitor this. Monitoring of this is very, very important. Monitoring of this is very, very important. Like improvement in the symptoms, improvement based upon the duration of antibiotics or duration of any disease, so this is very, very important, guys. This is very, very important to check. Like, okay, first day we started this, second day was it there or not, third day was it there or not, fourth day it was changed or not, fifth day what was the symptom signs and what was the improvement, and what antibiotic was continued. Like, you should do that. You should do the follow-up, and you should check how much the drug was taken, how much the drug was avoided, if the course was completed or not. We are not asking for outcome exactly. We are not asking for like long-term follow-up or something. If you are doing a DUR prescription pattern study, you should work on the rational use also, like how the drug change has been done based on the subjective and objective evidences. Based on the subjective on objective evidences, the changes in the medication happened. Okay, and next thing you can do it if it was according to guidelines or not. That tells you the exact rational or irrational use of medication. Understand? That takes you to the high right about the medication prescription or the prescription pattern of the drugs or any drugs. I'm just not talking about the antibiotics, but it takes you through the entire part. Like, if you are giving a medication, like that kind of study you can do in hospital patients also. Like, the patient came with patient came with high blood pressure, and then when the patient came, blood pressure was 180 90, and then suddenly the doctor, the patient was already on telmisartan, suppose, and when the patient came to the hospital, he was started on beta blockers also, he was started on amlodipine also, he was started on injectable nitroprusside also, and then the patient's blood pressure was controlled, and then he was at the end he was on the dual drug therapy, right? By cutting all the therapies subsequently, or they tapered the doses, and then they tapered the drugs also, and then they come to that. So my concern here is, when you are doing the drug utilization evaluation studies or prescription patterns, you must do in the correct manner. You must do in the manner something where you get the actual results, correct results, and some impressive results. Not simply like just to do the prescription pattern. You ask the you ask your students, like, go and do the prescription pattern of heart failure drugs. The patient, your student will go and he will check, ma'am, yes, I know now, 30% are diuretics, 20% are beta blockers, 10% are 15% are ACE inhibitors, and then rest are ibuprofen, or in patients they are giving some inotropes. Simple. This is not this is not the prescription pattern. This is not the prescription pattern means how it is giving, why it is giving, whom it is giving, and like how much it is giving. You have to check everything, and then you have to draw the conclusion by analyzing and connecting everything, with all the factors, independent factors, dependent factors, all type of things you have to connect, and then only you can do that. Okay, so that type of studies I'm expecting from you people if you are doing a core prescription pattern studies. I wanted to tell you that. Okay, and this is one of the best what we say DUR studies, and one of the impressive DUR study. If you are doing it, it will get published amazingly in a great journal, and such studies are again need of the hour, because the people who are working on the DUR studies, they don't do such in-depth DUR studies. Okay, guys, so did you understand? Any questions, guys? Here, please ask me questions here. I'm expecting few questions at DUR studies, please. I mean the core DUR here, prescription pattern studies. Yes, people. Questions, please. Which antibiotic prescribed based on patient complaints? See, no, see, I'm not telling you that which antibiotics are being prescribed or not. See, that is not my concern again. But I'm telling you like that you will find out after the DUR study, after the study what you are doing in the prescription pattern. You will come to know, like if usually the people with fever, usually what the doctor writes azithromycin. Go and take the azithromycin for 5 days, right? If I'm going with severe stomach pain, also stomach ache also, like, oh, I ate something in the last night, and you will tell, oh, your food poisoning, take some azithromycin. If you're going with cough, take some azithromycin. If you're going with running nose, take some azithromycin. So that is irrational use. Okay, that is irrational use. And when you are doing a prescription based study, prescription pattern study, you must understand, and you must check for rational use of any drug, any antibiotic, right? Yes, okay, then fine, perfectly fine. If it is parameter, perfectly fine. Yes, it is one of the major parameter. I told you, like what you are prescribing. Yes, absolutely correct. Yes, guys. Any other questions? I'm expecting the questions from you. Did you understand this or not? Did you understand, guys? Any questions, please? Any questions here? See, okay, it's very simple. It is very simple. It is very, very simple. Okay, see, I'll give you another example here. I'll give you another example here. See, the people with hypertension, people with hypertension. Okay, if suppose there is a blood pressure 130 by 90. Okay, let's not take 130 by 90. It will not be rational. I mean, it will be rational in India, definitely. I'll take it 150 by 100, or 150 by 90. 150 by 100, I'll take it 150 by 100. Okay, with this blood pressure, uh, the patient goes to a doctor. Okay, like the cardiologist usually take this care. Physicians also, take this, and then, not only cardiologist or physician, but other doctors also. I'll write clinicians. Clinicians also take care of this, right? So if the patient is going to these people, these all three will have different explanations, and different judgments, and different prescription patterns. Okay, maybe according to their guideline practices, according to their hospital practices, according to their own instincts. They three will have three different patterns. So first objective you can complete here. I mean, one more objective you can add: the prescription pattern among different healthcare professionals or different clinicians, different clinicians you can check out. Okay, right? Suppose if I'm going to cardiologist, focus here. Cardiologist must have read ACC AHA guidelines. They must have read European Society of Cardiology guidelines. Physicians must have just may not have gone through these guidelines. They may have gone through to JNC. Okay, JNC guidelines for hypertension, right? And these other clinicians, maybe some primary healthcare professionals and all, they may not have gone through any of the guidelines. They are just MBBS and maybe some other bachelor's degree. Okay, so guys, let me tell you here very clearly: if you're going to a cardiologist, he will prescribe the first medicine, which is first line drug, ACE inhibitors, like ramipril or enalapril. Or if the patient is not tolerated to this, then ARB, like telmisartan, olmesartan, olmesartan, candesartan, whatever, right? They will start telmisartan or this, because these are the first line drugs. If you're going to the JNC also says this, but usually what the physicians will do, they will start with amlodipine, right? This is the traditional practice in India, amlodipine. Go and they will give CCBs. They will give CCBs. They will not go to the first line therapy. They will start with third line or second line therapy. And if you are going to someone else, they may give beta blockers. Not sure which one they will give. If they give beta blockers, or if they may give some diuretics also. Chlorthalidone is very very much prescribed drug. Chlorthalidone, right? Or thiazide diuretics, right? Thiazide diuretics are prescribed. So this is something what you have to check. This is something what you have to check, and you can match it with guidelines, if it is guidelines directed medication therapy or not, directed medical therapy or not, and how much it has been decreasing in the blood pressure after 1 month follow-up or 2 months follow-up when the patient came to the hospital, right? So those things can be done easily for the rational use of I mean, this 1 month follow-up doesn't come in the rational use, but the guideline directed therapy for antihypertensive medications, in different hospitals by different doctors at different blood pressure levels, different people, you can definitely check it. Okay, and in that, like how much what was the drug prescribed in plain hypertension, what was the drug prescribed with hypertension and kidney disease, hypertension and diabetes, hypertension and heart disease. So these all can be done, can be checked for the rational use, and can be matched with the guidelines if they have given these drugs according to guidelines or not. But that is very important. You should not uh, you should not work on these things. I mean, you should not just stop yourself by percentage and all. You should check with the guidelines, and you should match with the guidelines. How much was according to guidelines, how much was according to the instinct, how much that gives you the real picture of rational medication use. Okay, rational medication use. Okay, understand? Any other questions, guys? Did you understand or not, everyone? See, if it is not interesting for all of you, please let me know. I'll stop here. Okay, I'll come to the core, how to conduct the DUI studies, and I'll finish it. But why I'm telling is because if you want to understand the DUR or DUE, you should know how to construct the studies, what kind of studies you can do. And this is the real time practice. Nobody will tell you. Nobody will tell you. This I'm guaranteeing. Okay. So now I'll come to something else. Right? Then what else is there? self-medication practices also we can understand through this. Okay. Another thing is, another very important topic here where you can construct the study is patient self-medication practices. Many people do that self-medication, and most of the thing of self-medication happens with antibiotics only. Okay, antibiotics and painkillers are the best self practiced medicine. Okay, sorry, left, right. So antibiotics, antibiotics and painkillers are the best example, best example of best example of self medications, right? OTC painkillers. So you can just check the, you can do a cross sectional study here. You can do a cross sectional study here, right? Cross sectional study here for OTC painkillers, for OTC painkillers in community settings. Okay, you can do such studies and you can work on that also. Okay. Sorry, yeah, what is this? I'll check it later. Let it be. I'll do it later. Yeah. So you can just check such studies also. You can do. Sir, can you refer any articles where prescription pattern is done in this pattern? Multiple studies, just check. You just check rational use of antibiotics or rational use of hypertensive medications, rational use of heart failure medications. Just type, nothing else you have to type. You just have to type rational use of any category of drugs you type, and you will get hundreds of the answers. Okay, you will get hundreds of the answers, right? You will get hundreds of the answers. Then again, with that, you can also do AMR studies, antimicrobial resistance studies. Antimicrobial resistance studies, what you have to do is you can just check like for how many days what kind of antibiotic was used, and like in that you can check the laboratory confirmations. You can check the which antibiotic was used. You can check the outcomes. These are the long-term studies. These are the long-term surveillance studies, we call them surveillance studies on antimicrobial resistance pattern, and these studies go for almost years, not only 1 year, 1 year, 2 year, 3 year, 5 years. And such studies also can be done with antimicrobial stewardship programs, like the interventional studies, like you are restricting fluoroquinolones on like multiple things, and you can check that okay, this antibiotic will not be given, or this antibiotic will be introduced newly to the hospital, and then you do the stewardship programs and all on that. Okay, you can do such studies also. You can do some population based trends also, population based trends like prevalence of statins among the adults with hyperlipidemia in urban and rural population. In urban and rural population also you can do. Okay, and if I talk about one more thing, I'll tell you about what was very important to discuss in this study types: personalized medicines. Okay, personalized medication or personalized medicine studies using DUE or DUR data. Okay, DUE or DUR data, personalized medicine. So what exactly you can do? What exactly you can do? So you can check one more thing here. You can check one more thing here. You can just, when we are talking about personalized medication, what you have to do is you have to look for some basic part of that. You have to look for some basic part of that, like, like some enzyme, or like some, genes, or like some, ligase of the genes, or, linkage of the gene, or gene alteration. You have to check for that. When I'm talking about medications, you have to usually check for the enzymes, special enzymes, or the genetic part. Okay, genetic part. Suppose I'm giving you the example here. This is a costly study. First of all, personalized medicine studies are costly, but still that is my duty to tell you. These are costly, needs a lot of funds to conduct such studies, and these studies needs lot of resources also. Not only the funds, in manner of the good laboratories and good expertise, right? Good expertise, and good technology. These needs any lot of things, and good training also to conduct such such studies. Like, but I have to tell you, you guys can conduct, if you have the facilities, you can conduct, you can collaborate and conduct such studies also. Like if I tell you, uh, you can check pharmacogenomics here. Okay, pharmacogenomics. How you can tell, how you can use the pharmacogenomics? Pharmacogenomic studies evaluating the role of CYP to okay, I'll write it separately so you can easily understand here. Okay, you can easily understand here. CYP to C19. Okay, role of P, okay, CYP, cytochrome P, 2C19 polymorphism. Okay, polymorphism in response to clopidogrel. Clopidogrel in preventing CVDs, right? So what does it exactly mean? See, so when we look at the mechanism of clopidogrel, I mean, let's understand about the clopidogrel. Clopidogrel is one of the antiplatelet medication. Antiplatelet medication means when someone gets the heart attack, the clopidogrel is one of the antiplatelet medicine which stops the antiplatelet aggregation and adhesion, and based on that, it prevents the clot formation in the coronary artery. Okay, so but how does it exactly work? Because it has the COX inhibitor. No, not sorry, COX inhibitor. COX inhibitor is in aspirin. Okay, so it has the cytochrome P in cytochrome P enzyme, which is also the receptor for for the platelets. Okay, so it covers all the platelet. It takes almost all the platelets to the drug surface, the clopidogrel surface, and it works in preventing the platelet aggregations, because it conjoined with the platelets with the cytochrome P, the clopidogrel, and it doesn't allow the platelets to aggregate. It doesn't allow the platelets to aggregate. But this all thing, when it happens, there is a polymorphism of cytochrome P, and based on that, the clopidogrel works differently in different patient. Like in suppose some patients cytochrome P 2C19 is there, some patients 2C19.1 is there, 2C19.2 is there, 2C19.13 is there, 2C19.99 is there. So there are multiple polymorphism has happened in cytochrome P 2C19, which is which is responsible for the clopidogrel mechanism in the body in case of preventing the CVDs. So that you can do with the help of definitely a genetic person. You can do the you can check the genetic polymorphism, like where the clopidogrel is not working. Sometimes clopidogrel doesn't work in the patients, and patient, even after taking the clopidogrel, they get heart attack, or they get the stroke, or they get the cardiovascular conditions. So in such cases, when the clopidogrel doesn't work where it is supposed to work, it doesn't work. What happens is it shows resistance. Okay, it shows resistance, and to check that resistance, we have to see if it is the correct cytochrome P. If it is the correct cytochrome P2C19 to work with the clopidogrel or not. If the polymorphism is not, if the polymorphism has happened and the correct variety, correct variant of CYP 2C19 is not there and not attaching to that, not attaching the platelets, then there is no use of clopidogrel giving in such patients, right? So based on the pharmacogenomics, based on the evaluation of the polymorphism of any gene, you can find out if this drug is for optimal use or not, if it can be selected for the therapy or not. So it helps a lot in DUE or DUR studies. It helps a lot in DUE or DUR studies. Okay, it helps a lot, right? So such studies also you can work on, right? And then in that, again, the biomarker driven treatments are there. Based on the biomarkers, you can do that. Like in usually nowadays, the cancer treatments are based on the biomarkers. Like we give the trastuzumab for HER2 positive breast cancer, right? So HER2 positive breast cancer means HER2 gene, or HER2 is the biomarker gene, which is present in the breast cancer, and if it is HER2 present cancer, if it is HER 2 positive breast cancer, then trastuzumab is trastuzumab is one of the best targeted drug for this HER2 positive breast cancer. Okay, so based on the biomarkers also we do such studies. Understand, guys? So these were some studies, some types of studies what we can do along with using the DUR, which we can do using the DUR. Okay, which we can do using the DUR. So that's there. And any questions till now, guys? Any questions till now? Guys, tell me any questions till now. Yes, people. Any questions? No? Did you understand? Okay, I'll take 10-15 more minutes. In one more thing I have to teach you. And then tomorrow I'll see. I'll take the class on AI and ML or other things for that. And steps of DUR, I'll start today. I'll explain tomorrow. Okay, it starts methodologies in DUR. I can do that. I mean, perspective and I think prospective methodologies in DUR, it's done, I think, right? Prospective drug utilization and retrospective, it is done. Right? Yes, prospective and this is done, right? That is done. Yeah, that is done. Yes. So today steps I'll take tomorrow. But before I go to step, I will talk about tools. Tools in DUE or DUR. What tools do you use or do you need in DUR or DUE studies? Okay, DUR or DUE studies. Okay, DUR or DUE studies. What kind of tools you need? What kind of tools you need? So first of all, guys, first of all, I'll give you one name here. I'll write one name here. You have to give me some examples. Clinical decision support system. Support systems. We call them CDSS. The first tool for DUE or DUR is CDSS. What is CDSS, guys? Tell me what is CDSS. What is CDSS? Can you tell me what is CDSS? Yes, people. I'm looking for your answers. What is CDSS? Clinical Decision Support System. The first tool in DUR is CDSS. Clinical Decision Support System. What is CDSS, guys? Anyone? Guys, tell me one thing. I want to know literally because today I'm not getting such engagements what I used to get. Are you understanding or not? Is it too hi-fi? Is it going above the head or you are understanding? Please tell me. If it is going above the head, then I'll come to the basics. But teaching basics in the 3 days course will not work because the first class was completely basics only. Because my first class was completely basics only, and that's why I wanted to take at least 2 to 3 classes on this, how to construct the studies, because use of DUR in research is important, and that was my target of conducting this course. Okay. Understanding? Okay, only 2 understandings I got. Okay, anyways, if you are not understanding, guys, I'm telling you, see, if you are the first timers to get such words or such statements or such different streamline of studies or something, if you are understanding that, I'll request you to go and check these words. I mean, check the recordings once, twice, thrice, note down these things and go to chat GPT and find out what exactly the things is, what exactly the thing are. Okay, just check all the things in chat GPT or in Google. You search and read. Okay, you check go and read, then only you will understand. So I was talking about tools in DUR. Tools in DUR. So what are the tools in DUR? First thing is clinical decision support system. So clinical decision support system, how and what do you, where it is used. Okay. So first of thing is, this is a real time, you know, real time thing. Then evidence-based data, evidence-based data, and evidence-based guidelines, or guidelines-based data it gives. So these things, real-time, evidence-based or guidelines-based data helps you in decision making, helps you in decision making and ensuring the safe and effective use of effective drug use, effective drug use, right? So clinical decision support system is nothing you check every day, guys. I'm very sure not every day, but you check frequently. First thing is, you must have heard of name up to date, right? You must have heard of name Medscape, right? You must have heard of name Micromedics. You must have heard of name, suppose Hippocrates. How many of you have heard of Hippocrates? I'll tell you, Google Scholar is not considered in that, but I'll tell you Google Scholar. You can check it. That gives the articles. Okay. So clinical decision support system is nothing but these are the real-time evidence-based guidelines based healthcare. These are provided to the healthcares to assist in the decision making and ensuring the safe and effective drug use. Right. So how does these work exactly? Where you usually go in emergency, check your work, and check your doubts, and you get all the guidelines based content there. You read, you confirm, like, okay, what I was thinking is correct, or what I was thinking is not matching the reality, so you change your decision and give some other medicines, like, or do that, it is for clinicians and you people when you check the prescription. So as a pharmacist, as a drug utilization reviewer, you should also know about these things, up to date Medscape and all, and you should verify the things, because these are the guidelines based things. And when you read these things and you check the prescription for drug utilization review, you absolutely get it confirmed, you validate it, and you check if it is actually correct or not. And that's how you check for the guidelines directed medications. Okay. So first thing is clinical decision support systems should be there or not. Okay. And the second thing comes is the second thing, which is widely used again everywhere. It is e-health records, right? E-health records. E-health records nowadays, EHR symptoms, EHR systems are very, very important. EHR systems are like nowadays after Corona, everywhere there is a centralized system to store the patient health information, like their medication histories, lab results, prescribing records, or maybe the data record, data things are there, discharge summaries. Those all things are in the electronic health records, right? After Corona, every hospital usually have the EHR. So you need the EHR. You need the AHR where you can collect the data of drug utilization review, right? You can check the things. And then pharmacy management softwares are there, and then prescription monitoring programs are there. Then data analytics and reporting tools are there, like, Power BI, SAS, SPSS, and then machine learning, artificial intelligence. These all things work in DUR or DUE studies, guys. Okay, these all things helped you in DUR and DUEs. So you must know about these things and you must use these things. So tomorrow I'll talk about the steps and then use of AI and ML in drug utilization review. Okay, tomorrow I'll take the class on drug utilization review on the latest fourth unit. So with that, I'll close the today's session, guys. Thank you very much. Today I did not get the instruction what I was expecting. What I was expecting, I did not get. Here is the form. You can fill your attendance form. So with that, guys, thank you very much and take care and celebrate the new year. Okay, and enjoy, guys. So thank you very much. Any questions? Please, I'm up for the questions, guys. I'm up for the questions now. Any questions? Please write. Yes, guys. Yes, people. Any questions, guys? Fill the form. Any questions? And if you have any problem, if you're not understanding, please write in the feedback form. Literally, I'm telling you, if you don't, if you are understanding, not understanding, if you have any problems, you please write in the feedback form. That's okay. Okay, I will take it positively. Yes, guys. Yes, people.